This is a presentation for bisphosphonate-related osteonecrosis of the jaws. A 50 years old female, her chief complaint intense spontaneous pain in the mandibular right side after a prosthesis replacement in an implant area that was installed 16 years ago. The review of patient's medical history revealed that she started a therapy with Fosamax 70 milligram once a week for the treatment of rheumatoid arthritis in 2004. The patient had no history of smoking, radiotherapy, infectious process, or trauma in the maxillofacial region, and the dental implant presented normally until the symptoms began. Upon clinical examination, a mild erythema was evident in the mucosa surrounding the distally right dental implant, without clinical evidence of purulent discharge, gingival recession, or bone exposure. However, propping revealed increasing depth values and detachment of the mucosa from the peri-implant bone, with biological seal loss, was observed. A computed tomography (CT) was requested and showed a substantial radiolucency around the involved dental implant, featuring loss of the crystal bone. Peri-implantitis was the primary hypothesis considered at that time, but also considered bisphosphonate related. The initial treatment plan was mouth rinsing with chlorhexidine 0.12% 4 times a day, and antibiotic therapy with clindamycin 300 milligram twice a day for 10 days. Since the patient had allergy for beta-lactam antibiotics, surgical decontamination of the implant surface was also planned. However, upon mucosal flap incision, there was no indication of any exposition of implant threads, but there was a large zone of necrotic bone forming a sequestrum area. Therefore, it was opted to removal of the implant with sequestrectomy and debridement until a bleeding bone was observed. An interrupted suture was made with 4.0 silk in an attempt to close the wound, primarily without tension. After medical consensus, alendronate was suspended. The bone specimen obtained was fixed, processed, and paraffin embedded for histological analysis. Hematoxylin and eosin staining was used for histological observation by light microscopy. The results revealed necrotic lamellar bone fragments with chronic and acute inflammatory cells, as well bacterial colonies. Bisphosphonate background: presence of exposed bone in the maxillofacial region. Its pathogenesis is still undetected, undetermined, but may be associated with risk factors such as rheumatoid arthritis. Bisphosphonates are a class of drugs commonly prescribed for bone diseases due to their osteoclast inhibition property. This class of drugs has been widely used for osteoporosis and corticosteroid-induced osteoporosis in patients with rheumatoid arthritis. However, reports of bone necrosis induced by bisphosphonates have generated great concern regarding the side effects of these drugs. Although rheumatoid arthritis has been considered a risk factor for this kind of osteonecrosis, the relationship between these diseases has not until now been completely elucidated. Rheumatoid arthritis is a systemic autoimmune disease characterized by progressive joint restriction and a variety of systemic manifestations resulting from chronic inflammation, which has been considered a risk factor for the development of that disease. Although some features seem to link rheumatoid arthritis with the oral bisphosphonate condition and act as synergistic effects, more studies should be developed to support the scientific basis for this hypothesis. In addition, most patients with rheumatoid arthritis and oral bisphosphonate condition are diagnosed in stage 2, which indicates the necessity for rheumatologists to be aware of the potential risk to their patients of developing. This is the end.